Hello, and welcome to another segment in Outcomes Experience Academy. My name's Jason Holland, and today I'll be discussing tailoring ocular surface disease assessment and management in a private clinic. A little bit of background as to why this is a topic which I'm quite passionate about is our clinic in Brisbane, Australia focuses on excelling in trifocal and extended depth of focus intraocular lenses. If you look at the penetration of this type of implant in Australia, it's only about 6 to 7% of all intraocular lenses. In our clinic, we implant upwards of 80% of intraocular lenses to correct presbyopia. And of this, over 70% are toric intraocular lenses. What I'll share with you today is the reason why we focused heavily on ocular surface disease management to achieve the outcomes when implanting the number of implants that we do of the trifocal nature. Here's an example which first opened our eyes to the need to respect the ocular surface. Here's a 60-year-old male who came in requesting a presbyopic intraocular lens. The patient had done his research and did not want monovision. He wanted a presbyopic intraocular lens. And you can see at baseline here, his axial map scan shows considerable irregularity in the topography. He's a moderate degree of astigmatism, and the axis is at 150 degrees in the flat meridian. And the formula suggests an intraocular lens of 20 diopters. We flagged this patient though with dry eye and commenced him on intensive topical steroids and ocular lubricants and asked him to return in a month. You can see a month later how much his axial map topography has changed. Indeed, it is more normalized. You had a change in the axis of your astigmatism, but indeed also the power of your intraocular lens. Now you might argue, look, if I put in a 20 rather than a 21, I'd only be half a diopter out. But when you're aiming for a mini monovision with a need of intraocular lens, this can be the difference between success and failure. Another reason why we focus so heavily on the ocular surface in our practice is that when you're adding a trifocal intraocular lens and the inherent aberrations that come with it, the last thing you want is the tear film itself adding aberrations to the visual system. You can see here on a patient with a normal tear film osmolarity that their ocular scatter is very stable and indeed very low. And if you're still on ocular lubricant, there is no change to that scatter. In contrast to this, a patient with dry eye disease has a raised osmolarity, and you can see how even after instilling an ocular lubricant, it takes 15 minutes before the scatter in that tear film normalizes. This is why it's very important when implanting trifocals to ensure your patient has a stable osmolarity and indeed their dry eye is being actively managed. So how do we do this? We run a busy private clinic, and one of the first things we ensure is that during case history, we actually go out and hunt and seek for dry eye. Even if the patient says, oh look, my eyes feel okay, we might ask them, do you ever use an ocular lubricant? Do you have any eye drops in your cupboard at home? What's in the back of your golf bag? We need to know if they've ever suffered dry eye or felt the need to buy ocular lubricants. We ask them about previous contact lens wear because we know this can make them more at risk of a mammalian gland dysfunction. We also use questionnaires, and look, some practices use the OSDI or the SPEED questionnaire. We actually have developed our own questionnaire in-house, and to this end, it assesses the risk of dry eye being part of the patient's life, but also lifestyle questions to assess, do they work in dry environments? Do they find that their weekends they decide to jump from an aeroplane and go skydiving? Do they work on planes and fly to London every second week? You need to know about the patient's lifestyle to manage their ocular surface to get the best possible outcome. We also have a team of clinical optometrists, and when a patient presents to the clinic, there'll be a number of diagnostic tests performed. The optometrist will do sodium fluorescein staining, lissamine green staining, and indeed, if the symptoms suggest, a Schirmer test. The patient then sees the ophthalmologist, who will also do gland expression at the slit lamp, which is a great segue to discuss the fact that their other tests may be abnormal and that indeed they have dry eye disease. If any of the symptoms or the diagnostic tests are abnormal, we red flag this for the surgeon, and indeed we suggest the patient come back to our specialised dry eye clinic to be managed, for their ocular surface to be improved before we book their surgery. And often this means a delay to their surgery, so it's important to educate them how important their ocular surface is and why we are making their surgery be delayed. In our dry eye clinic, which is usually run on a day when the surgeon is in theatre, we then go on to add further weight to the diagnosis. We use the tear lab and the Keratograph 5 to measure the tear film. And indeed for me, I love the fact that I can show the patient an infrared video of their tear film and how it breaks up and how the tear film dries out and get the patient involved in their dry eye disease. We then look at the management. And this is often a challenging process because not every patient is open to the idea of gold level top shelf management. You have to find what suits the patient's budget and also suits their time. Some people are very open to the idea of doing hot compresses and lid hygiene at home twice a day. Others are just too busy or don't feel they can be compliant, in which case you look at in-house management procedures. Some patients even have a mixture of both, where we give them homework, but they come back to our clinic regularly to be managed in-house. And really, I think for us, the real eye-opener was the difference that we find patients eventually choose in terms of getting the ultimate outcome for their dry eye management. Once the tear film is stabilised, and this can take anywhere from a month to 3 to even 6 months, we get the patient to return to be remeasured. We remeasure every measurement possible and compare them to the preoperative data. We then often reassess intraocular lens choice and then book their surgery. At this point too, depending on how well they've gone with their dry eye management and indeed how hard it has been to normalise their ocular surface, we may even modify their post-operative drop regime. This can be looking at unpreserved antibiotics and steroids in the immediate post-operative period, indeed providing unpreserved lubricants and lubricant counselling. We also explain to the patient that their visual recovery may be slightly longer due to their tear film needing a longer time to recover. I also want to touch on astigmatism. I have seen quite a lot of research done in regards to the effect of the ocular surface and astigmatism. And when you're quite commonly correcting this with your intraocular lens, you need to ensure that what you're measuring is indeed what your intraocular lens is going to correct. And to that end, we know that dry eye can dramatically influence not just the degree of astigmatism, but indeed the orientation. And as such, for us, it's very important to correctly assess the astigmatism over a healthy and stable ocular surface. So you performed your surgery, you managed the dry eye preoperatively, it's now the post-op period. And for us here, review is critical. And indeed, staying close to the patient and talking to them regularly. We contact all of our patients at 3 months to assess how they're going and indeed ask how their eye is feeling. Patients who have had significant ocular surface problems before surgery, we get them to come back to our clinic at 6 months. And then generally we discharge back to their original referrer at 12 months. For some patients where a referrer has no interest in dry eye or has no access to dry eye treatment strategies, we will keep them in-house to manage them long term. We also like to discuss other potential impacts on their vision over the next 3 to 4 years. For example, posterior capsular opacification, and the fact that surgically you might discharge the patient at 1 month, but their vision may take 3 to 4 months to fully adjust to the new trifocal intraocular lens. Other points we like to mention to our referring optometrists, both at CPD events which we run in terms of education, but also in our discharge letter, is the fact that halos and adaptation takes time, and that indeed patients may see a small halo for the life of their lens, which indicates that the lens is working and the light is being bent to let them see. We discuss the role of posterior capsular opacification and the need for a YAG capsulotomy, which can be more common in patients as they are often younger when seeking out refractive lens exchange. We discuss the long-term need for dry eye management, the need for sunglasses, and indeed the importance of going back to their original optometrist for ongoing eye health exams. I think completing that loop back to the referring practitioner ensures that if you decide to increase your trifocal intraocular lens penetration, that you'll keep your referral base loyal because you'll return the patients to them after surgery. I hope today's presentation has given you some insight in how the ocular surface in regards to intraocular lens selection, and by tailoring your ocular surface management, you can achieve the best refractive outcome for your cataract patients and indeed refractive lens exchange. Thank you very much.